Giving folks a few minutes here and we'll get started. Should be streaming live on DSS YouTube channel as of now. Olivia, I just changed. You should be able to share screens.
Great, thank you.
Great. We'll give folks one more minute and then we'll get started. All right, I think we'll get started. Good morning, everyone. Welcome to the March 7th Primary Care Program Advisory Committee meeting. And I just wanted to acknowledge that we scheduled this at a time when we have a Human Services public testimony. So I know both Guy and the Commissioner are unable to join, and there may be actually some participants who are busy. I'm sure many of you have been following along, and so apologies for us, but we didn't want to reschedule it, so we're moving along, and I'm lucky to have Dr. Dalal here along with me today from DSS, and I think you all know him from prior meetings. So again, as I mentioned, we're live streaming, recording this, so if folks weren't able to join, they can always watch this later. So today we're going to be talking about the health equity strategy. We'll do a review and discussion on that. And in addition, there was an ask from this group to review our health-related social needs in community sports conversations that we've been having. And so we'll review prior conversations and open it up for further comments. I do want to just make a note at the outset that there really are limitations to what we can address for health-related social needs and community supports in this process. But we recognize it's such an important topic that we want to hear from all of you and make sure we're hearing the comments and voices on this. But I do want to acknowledge some of those challenges that will be faced in actually making significant strides in this area at this time. So, and then at the end, we'll do our wrap up. So I think we jump right into our goals for the day. So again, kind of review and discuss the program's cross-cutting equity strategy, taking stock of the different components we discussed and identifying additions or modifications. And I think most of you have probably recall that we've really included the equity throughout and tried to pull it in where we thought it seemed to make sense. And many of you have added to that and helped build out that throughout the process. So it's not a separate, completely identifiable equity strategy. It's really tried to be built into the rest of the conversations we've already had. And then again, we'll be doing that revisiting of the HRSN screening and community supports discussion, looking for all of you to weigh back in, and we'll remind you of that discussion today. Great, we'll move on to the starting points based on our prior discussion. So we've had these conversations. This is just a reminder. We talked about the program design components. We talked about care delivery, performance measurement, and payment models. And we most recently, again, visited those payment models. And today, as noted, is really how do we address inequities and racial disparities? And that's that. That's, yes, but just as a reminder where we've come so to date. Go to the next slide. So our equity strategy review. So really our goal here is to discuss that strategy and take stock of it. And how we're going to do that is just review the starting point on previous discussions and then any additions or modifications that you all have. So again, next is really what we've discussed today in this space, and then going to you all to say, have we missed something? Are there other things we should be considering? Go to the next slide. So in each of these, on the left, again, are kind of the three major domains that we've discussed: care delivery, performance measurement, and payment models, those key questions. And then you'll see on the right, the equity components that we've already discussed, and we're just going to highlight those. So I'm going to walk through them just so that we're all on the same page, and also remind you of that so you can add additional commentary or feedback to say, yes, this sounds right, or no, we're missing something here. So under care delivery, you'll see the integration of community health workers, HRSN screening and referral, the use of health-related social needs and social terms of health data to implement interventions and prioritize needed community resources, the requirements for competencies in care of individuals with disabilities and/or ADA training for care team members, adherence to national standards for culturally and linguistically appropriate services class. Under performance measure, we identified the collection of race, ethnicity, language, and disability, REL data, and performance measure segmentation to identify and track reduction of disparities in quality of care and member outcomes at the program and provider level, use of patient-reported experience measures, use of process measures related to screening for and addressing health-related social needs, and under payment model, performance-based payment tied to collection of REL data and/or performance on population segmented measures. Additional base payments that provide care flexibility and funding to support care delivery and performance measurement priorities, medical and social risk adjustment that account for patient needs, and multi-track program that enables broad-based provider participation. So again, these are the components that have been weaved in throughout and that are informed by the conversations today. And so next, we're going to jump right into discussion. And so with that reminder, I'm going to open the floor up and ask all of you, are there other components that should be considered as part of the program's cross-cutting equity strategy, things that we didn't identify that should be weaved in? Again, reminding you all that we are going to have a further discussion later about those community supports and health-related social needs screening. So let me stop talking and it up for any comments or discussion. Alice, please. Oh, you're on mute.
Hi, Brad and team. Everybody, nice to see you. I just want a clarification on the point you have on payment model. The word flexible, delivery flexibility. Did we in this group talk about flex funds per se? You know, because as we're, and it can come up in the HRSN conversation, but I don't think you meant flex funds there, right?
When you say flex funds, you mean funds that really are flexible for addressing potential like HRSN needs? Is that?
Yeah.
I don't believe that came up, but I think sounds
okay.
like what you want to make on it. So great, go for it.
Yeah, we can make. I mean, that's been our experience delivering wraparound care coordination across the state is really around having the ability to have those kinds of funds. But I think it will come up more in the HRSN. The other thing that I am embarrassed that hasn't come up for myself is really understanding the level of chronic stress the families are experiencing. And, you know, be it through trauma, you know, a trauma screener or some sort of quick and easy sort of understanding of the, you know, either interpersonal or social violence exposure. You know, when we're talking about equity, health equity, and we're talking about the biological implications of high levels of stress, it would be important that we do think about that, and, have some sort of screener or, we screen for depression or anxiety, but I don't know if we do. We have been doing a lot of PTSD screening in the schools and are finding about 60% of the kids are screening positive for that. And so, just making sure that when we're talking about that, and also on social connectedness or disconnection and the role of the family in their healthcare.
Thanks, Alice. Polly?
Thanks, Brad. A couple of comments. I had the opportunity to review the deck with our executive director for health equity and one of our physician leaders. Some things that they called out. We recently launched a campaign called We Ask Because We Care, supported with some funding through the Connecticut Health Foundation. And just reiterating some of the lessons learned where we're asking for race, ethnicity, and language data, and that it's really critically important, not just to educate the clinicians about why we're capturing this data, but also the community and the patients. Kind of related to this, I lead a lot of our social determinant screening work at the health system, and we have a health equity patient family advisory council. And we went to them earlier last month to talk about the SDOH screening. And they said a couple of things. They prefer to complete questionnaires like privately, so considering how to collect the information in a sensitive way. They also really wanted to understand the why. Why are you asking me these questions? What are you going to do with the information? How is it going to be beneficial to me? So we did hear that directly from our patients and family advisors. And then the other thing, I think it called out competency around disability and language, and they just flagged a few other maybe special or vulnerable populations that they had experience working with, including refugees and recently incarcerated populations. So where wraparound services were really important. So maybe just fleshing out what we mean around competencies for some of the unique or kind of subpopulations that are prevalent within the Medicaid group. Thank you.
Thanks, Polly. Angela, and then Alice, your hand's up still, but that may be a legacy hand, but Angela, please go.
Yeah, so I don't want to jump the gun because I know you said that community supports we would be talking about later. But I do have a question. You had mentioned up the top community health workers. Are you talking about community health workers only embedded in the hospital setting, or does that include community-based organizations?
I think this is mostly in the setting of primary care reform. So it's really focused on including them in that broader scope, not saying that they couldn't be included outside of it, but really within that window of like what is primary care and what we're talking about. So that's, but acknowledging, I think Angela, you can please add more about the need for them to be in other places.
So community health workers are, in my mind, the boots on the ground and connecting families and patients to the services, navigating through systems. And if you don't have a relationship with the hospital or the provider, that person might, that trusted person might be more likely to be in the community. And so in this conversation, wanting to make sure that the funding streams go to where the actual workforce is, that can help folks navigate through the systems.
Thank you, Angela. I'll just quickly flag, many of you may have been involved in passing legislation last year that had DSS come up with a plan to institute payment for community health workers. We are in the midst of working on finalizing a stakeholder plan within DSS and how we're going to do that. And there'll be more information forthcoming about broad CHW engagement and or what that might look like under DSS. So I just want to flag there is a separate but related component of work that's happening at this time. Great, appreciate the comments. Any other thoughts? One question I think is in terms of the maybe Polly, just something that came with that you had said, is this something that some of the work that you highlighted that's happening with your organization, are those things that should be mandatory or just best practices that are developed over time? And what's the role of kind of payment reform for helping kind of frame some of this or require it? Curious your thoughts if you'd like to share.
Yeah, I mean, I think, it will be multi-pronged. Like, for example, if we think about the why and why we're asking for this data, I think, DSS would also have a role in setting, some of the community groundwork as to why with your members overall and how you're, what you're like looking for the providers of care to do with this, information and how it will be helpful for them. So I think some of these things require many voices, to share the message, and to help think through like who are some of those trusted messengers that, could be reflected, to share some of that information. So, I don't think it's unique to any one organization per se to do this, but it might be incumbent on DSS to offer or develop some of these, special population training sessions. And how do you think about the needs of those populations? And how do you equip our organizations with better information to disseminate out so that we're not all each individually needing to create those things, but it can be speak with one voice and with a common set of messaging and supports.
Thanks, Polly. CJ?
Hi, thank you. So I just want to suggest that while we are considering and strategizing, and while I appreciate that Connecticut, we're all about learning and education, we love to study things, let's resist the urge to turn a need into a study. And also, when we consider outreach, impact funding, let's keep in mind diversity also includes who's providing the services. So let's ensure that we make space for the not so big yet Black and brown agencies so they could participate. And let's consider the fact that we're in a time in history right now. People are stressed out. They're very stressed out. The last thing they want to do is be treated like a test subject. Just wanted to add that in there. Thank you.
Thanks, CJ. Any other thoughts or comments people would like to add? Again, focusing on the discussion to date on our cross-cutting equity strategy and things that either we've gotten right or maybe we're missing. Mark, please.
Yeah, just lowering my hand. I somehow feel we're missing something in this conversation, and I don't know what it is. I feel that there's, Dr. Richards, a ton of work that's been done around health disparities. We were working on this in the early days of SIM. There are huge disparities in A1C outcomes, amputation rates for Black versus Hispanic versus or Latino or white. There are these huge differences in cardiovascular death rates between Black and white individuals in Connecticut. And so we've got the HRSN screening and use of community health workers and primary care settings, but I don't really. I'm having trouble putting my finger on sort of what it is that we're doing and whether we've surfaced all the ideas that could help to close these marked disparities. I would add asthma to the list there. And so, and I'm not expert on what's going on now. I know that I've heard systems that are looking at, say, follow-up for prostate cancer screening or mammography screening, or even rates of getting colonoscopy and mammography screening and how those are different. Both are very effective preventive measures, and there are different participation rates for different communities. And it just seems as though HRSN screening and CHWs is not really, there should be more than that, more evidence-based ideas for how you can actually address the disparities.
Thanks, Mark. And I think maybe I'll just reflect back that, I know we've talked about this a little bit, is that like primary care probably isn't the place that's going to be able to it can't be the solution for all of this. And I think you're right. There's a lot of other things that could be done in various ways, and some of those may involve primary care and some may not. So welcome.
Do you think, I guess, do you think that we've exhausted all of what can be done in primary care?
It's a good question. I'm not sure. I think,
there's health literacy issues. There are differences in the extent to which individuals fully understand why certain prevention measures or screens are recommended, or methods for ensuring outreach when there is a positive screen that needs follow-up. It's just, so I know that I've had this whole sort of narrative that I've been sort of advancing on what needs to happen around primary care, but I also think that there's just a ton we're missing about the science of improving the engagement and the health literacy barriers, and so I sort of get that there's all that needs to stuff that needs to happen in the community, but I feel that the portfolio of things that are under consideration that can be done in a primary care office, we're just scratching the surface here. And not that I think there should be, highly prescriptive requirements as to what folks should do, but that we should be more generative in terms of what's the state of the art in clinical practice settings for mitigating these disparities.
Maybe I'll just quick, and I think Mark, I think quite aligned with what you're saying, and I think being cautious about how prescriptive we are, especially as different populations may have different needs, but how do we still maintain a focus so that we can push, if Medicaid's paying differently for primary care, how do we make sure we're focusing on those things where, and that's where it seems like if we have big outcome markers that might be helpful, including patient experience and satisfaction, or cancer rate screening, or other things that we've started to talk about. I think there's probably a balance here, and I think this has come up a couple of times in terms of being prescriptive when it's necessary, and driving towards bigger outcomes when we can, to get there. But this might be part of what we build as a structure, thinking about learning collaboratives or others where we continue to engage, where people can learn from each other. Maybe there's work happening in one part of the state that's useful for other parts of the state to learn from. So I want Alice, I see popped a bunch of hands up. So I think you started some good commentary. So Alice?
Yeah, no, I think, Mark, you're correct. From our experience, there is something about saying it in a primary care setting, but if a community health worker is really trained in terms of some of the health supports that can be made, and if the community health worker is able to engage with in the home or with the family, that we found actually a very hard to reach group of men over 50 when we were in the house actually participated in care much easier because it was around the kitchen table and there was conversations that were had around what they might need and, sort of prompted to, follow through. And so, when we're talking community health worker, I know that there's a lot of work being on that, but I think really making sure a health worker is trained in the social drivers, the physical and mental health of a family or an individual, and that they're allowed to engage with the family in their home also. So it's not just office based.
Thanks, Alice. Polly?
Yeah, I echo that our experience with our community health workers, one of their key responsibilities is health literacy. That is a big area of focus and skill set that they do bring to the table, as well as being able to go out, meet the patient where they're at, help get them to certain follow-up appointments, things like that. And I did want to reiterate on, and Brad, you can cross-check me on the payment reform. I think some of what we're anticipating is being able to stratify things like blood pressure, diabetes control by these various like race, ethnicity, language, other variables. And where we notice a different differentiation of performance, then we're going to be expected to use our resources to do something different, to close that gap. So I think a part of this is, do we have the right data tools available to all of us to risk stratify, to stratify against these health, various health equity measures? And then, we do have tools at our disposal where we are outreaching, engaging, actively pulling people in, pairing them with a CHW. So it may just be lifting up that component of the plan and highlighting that a little bit more. So it really jumps off the page as part of a key component of how we'll be accountable to closing the gap, not just in the overarching performance of certain quality or performance measures, but actually kind of closing the gap in any identified disparity.
Thanks, Polly. And Mehul?
Hey, good morning, everyone. I was going to respond to what Mark says, but some of it might have been encompassed in the comments that followed. But I guess I'd put an example out there just for consideration. So to me, the equity strategies, I think, should be viewed as a sort of a condition for potential success to close the equity gap. So like, to put it in concrete terms, if, for example, a primary care practice or system wanted to focus on hypertension, are these strategy components sufficient to enable that success? So for example, if you want to get hypertension control and close the equity gap in hypertension control, integration of community health workers, there are evidence-based models of integrating community health workers in the care of hypertension in the care delivery category. Performance measurements, we all know that for many years have been hypertension performance measures that we could track, and we should be tracking by race, ethnicity, and demographic breakdowns. And then payment models is what we've been talking about. We have a range of options to incentivize better control. So I'm thinking like Mark, I sense what you're saying about something feels missing here, but I feel like that missing piece should be filled in, and that's part of the flexibility that would be offered by these foundational, characteristics. And you could take an example like diabetes, asthma, and run it through this matrix and see if that will work as well.
Ben?
Thanks. Hi, everyone. First, I'm really glad that Mark raised this question. It was very provocative and leading to a good conversation. One of the things that I have been reflecting on as I read what was posed on the prior slide is it does, I think that Mark is pointing us in the right direction, the direction that we need to get to. But I think what you laid out reflects the reality that we're not yet as a system doing a great job of collecting this information. And so it feels like this first step of collecting and then analyzing the information, and maybe that piece could be strengthened, like an expectation that the practices are not just collecting the information, but evaluating the information, putting together plans. I just think we need to, like, in this iteration, it feels like the collection of information and the analysis and the identification of opportunities feels like the right next step. And then in the next iteration, once we know that we've got better data collection, we know what interventions we might want to make more of a mandate.
Thanks, Ben. Angela?
Yeah, so I have two concerns. One, and in 2024, you think this would not still be an issue, but just basic language competency of providers to engage effectively with patients. I literally watched and had to bite my tongue to not get involved, but watch just at intake. So just filling out your intake forms where, I don't know, there's 3 or 4 forms and only 2 were available in Spanish. And then the person didn't provide an interpreter, and the patient brought someone with them, but they weren't familiar with the jargon on the paper. So, in 2024, we shouldn't still be having this issue. And so accountability and holding folks to current standards, before we think about new standards, can we hold folks accountable to existing standards and put measures and training and workforce development in place and sufficient staff to address the needs of patients? Full stop. The second issue revolves just around the integration. There have been so many models put forth, Mark Mission Sim, and we have health enhancement communities. There's all kind of different cross-sector, multi-institutional, just different models that have been put forth throughout the state. How are we using those existing models to implement some of this work so that we don't keep reinventing the wheel? Are we building upon existing structures? Are we constantly, starting from scratch all over again?
Thanks, Angela. Tiffany?
So I echo a bit of what Angela is alluding to. And so, Mark, I hear you. And I think we all would attest that this isn't everything. And in addition to that, we have to figure out how this work, this primary care work, fits into other reform strategies that the state is executing. And to Angela's point, how does it fit in with other models the state has up and going and has tried? Additionally, I am all for the additional data collection. I appreciate that being raised because we've got to learn, and our system has to learn how to address equity. We can't make the assumption that a lot of our practices are even going to be ready day one. And so part of this is that, yes, I agree that this isn't everything, but this has to be a start. What can we learn from implementing this well? And what can we learn that we can apply and grow in the future? And I think that this would be a great way for us to get started, to do the data collection, and to understand where we continue to have breaks and failures in our system. And to Angela's point, to even just get our providers to focus on equity in a different way that some are not focused on right now.
Thanks, Tiffany. Angela, your hand's still up. Did you want to add something else?
Sorry.
Oh, no.
Let me see.
No worries. CJ?
I just want to chime in there. So I know that I want to take responsibility for my comment about the data because we're very studious people in Connecticut. But I also want to draw attention to what was just said, because in truth and in fact, our Black and Brown people in the healthcare field, as well as other places of work, are not being treated well. And they are front line. We need to look at that. We need to unlearn certain behaviors, right? That's a different thing. That's a whole different kettle right there. So I hope that what's being said is really being paid attention to, because, you know, I respect the work of DSS, and in the bigger picture of things, what's being said to you is really to ease the strain on all of us. So I hope that's really taken into consideration. Thank you.
Thanks, CJ. Really appreciate all the comments, and Mark, thanks for kicking off with some helpful commentary. I think some additional useful feedback. Seeing no further, I think we can move along, because I think this will move us into that next section a little bit about health-related social needs screening and community supports, which we had, again, we talked about a decent amount at this point. And so the goal here is really to provide a recap of that conversation to date, a summary at least, and then kind of summarize some of that feedback, and then get some additional feedback from all of you on this topic. So you'll hear a little bit more from us. So on the next slide, you'll see us kind of the recap, which I think is like pretty significant. And you all pushed to have additional conversation on this last year, as you probably recall. And that's really started last July. And so you'll see here, we really kind of delved into it in that July 13th meeting, talked about a framework for addressing health-related social needs, and provided an overview of some of the work that DSS and others are doing, and then talked a little bit about how other states are handling addressing HRSN needs through 1115 waiver strategies. And then we had the listening session separate from our or in kind of a additional meeting that you all had raised for us. On August 3rd, we kind of summarized that a bit and shared some examples with you all of what other primary care programs that have done to integrate this into them, including some of our neighboring states like Massachusetts. On October 26th, we discussed a bit about the primary care capabilities that we wanted to prioritize, and you all helped us kind of rank HRSN screening community supports third highest on the priority list. And so that's maintained a focus for us. And then we also talked about what the role primary care practice should play. We talked about what are those various options. And there's a large contingent of you that said really that it should be primary care should be doing screening, referral, and or coordination of those services. We revisit a little bit on the 7th, where we provided some feedback on measures and requirements that we could use to drive HRSN screening and community supports in that domain. So we identified a few aspects of how we might measure that. And then in January, we talked about the importance, or you all raised again the importance of this, the importance of community investment strategies and the need for that. And so we wanted to make sure we took time to do that. So on the 8th, there was a suggestion to have a broader financial accountability structure to ensure that dollars flow to community providers, so that if you refer someone, they're not necessarily just on a long wait list, or in other options, including BH supports. So that's just kind of where we've come at a high level summary. Mark, I see your hand up. I'll turn it over to you to see if you want to add anything else you think we missed here.
So Dr. Richards, I know I wasn't sure when to raise this, and I know that where you're heading in terms of other things that could happen from a reform perspective that would maybe take on some of this stuff. But I would like to, especially since this is maybe one of our last meetings for this phase of work, I wanted to see if we could get a read from the members of this committee as to whether, because it says here 85% voted that primary care practices are expected to perform certain functions related to screening, referral, and or coordination regarding HRSN needs. We have been working with the hospitals, as we talked about previously, to implement the screening statewide for SDOH, or excuse me, HRSN, health-related social needs. Some of our systems are doing this now in their physician practice settings. So we have an unprecedented level of screening that we're aware of going on in our hospitals and systems. We know CHN Connecticut is doing a ton of it, and we know that many of the FQHCs are doing screening. And what we're experiencing every day is a profound lack of capacity that is making it really hard to connect the people whose needs have been identified with the services that could help address those needs. And this isn't like a little barrier, this is an enormous barrier. And so what I want to test out with the committee is whether we want to go statewide with thousands of primary care practitioners that universal screening for SDOH, if the state's not willing to cover HRSN services. In my view, to screen without addressing capacity is really they are connected, and you're setting up for frustration with providers having to figure out how to close loops that are impossible to close for lack of resources. So for me personally, I would say the recommendation for HRS screening in primary care practices in the Medicaid program-wide, that recommendation, in my view, should be conditional on the state's willingness to fund additional HRSN capacity. Otherwise, it will be an exercise in frustration, both for the patients and for the practitioners. That's my sort of rebuttable presumption.
And I thank you, Mark, for that. And maybe I'll just, and Alice, I see your hand up. I might just ask we put a slight pin in that, so because I think it may be influenced slightly by kind of what's to come to a degree, in terms of at least us reviewing a few other opportunities. With that said, obviously we need to jump into that part of the conversation. So maybe we'll just quickly go through that, and then we'll get to that so we can make sure we capture all of the comments. So I'll just hold that, and I see Alice, and I know Angela, your hand's up too. So just hold that, and I'll get to you next once we get to some commentary, so we can get there. But thank you very much, and Mark, I think appreciate your kind of raising that question. On the next slide, I just want to highlight. I think, Mark, to your point, we've previously it's kind of said, we should be doing screening, referral, and coordination. I think you raised the question of, is that wise if there's not enough access in the community? And then community members seeing value in integrating CHWs in care teams. And I think we heard already the need to think about CHWs outside of that capacity as well. The concurrent investments in community supports are critical, and I think that's exactly what you're saying now, Mark. Without concurrent investments, there's a risk that they'll be referred. And I think you're not saying there's risk, you're saying that's already happening, and that the diminishes the value of screening or referring strategies, and that we at DSS should consider how to develop a financing accountability mechanism that enables participation of a broad range of actors in the community and healthcare system who are critical to HRSN. But DSS should and can't shoulder this alone, and should partner with other agencies as a broader statewide effort, including multi-agency partnerships and collaboration. One of the other things on the next slide that you'll see that we're continuing, and this is kind of our next steps, is one is to kind of move forward, and we'll have this conversation in a moment where we get more input on what you just raised, Mark, and probably others from Alice and Angela, I assume. And I think really just trying to support this statewide effort to invest in communities even outside of DSS. Connecticut is exploring the AHEAD model, and I think that's come up a little bit, but for those who are less familiar, this is a CMMI, Center for Medicare and Medicaid Innovation model that is being looked at by Connecticut with OPM DSS and other state agencies, and considering applying for it in very short order. Applications due in just a few weeks. And it stands for States Advancing All-Payer Health Equity Approaches and Development Model. I think we can go to the next slide because we'll get to this in a second, but just broadly speaking, the goals are to AHEAD's goals are to curb cost growth, as well as improve population health and advance health equity by reducing disparities in health outcomes. And there's some key components. Won't get into all the details, but really we'll then lean into the areas that we think that could be opportunities for some of this to move forward and pivot on. But the three major components are statewide accountability targets for cost growth, primary care investment, and also health equity and population health. And then there's hospital global budgets, and then there's also a primary care AHEAD model, which we briefly brought up at a prior conversation. And the pieces related to health-related social needs and community investments here are really, you'll see here, these bulleted are a model governance structure, and states are required to form a multi-sector model governance structure, a guide to implement the model. And that has to include various stakeholders, including providers, payers, community-based organizations, and patients, to ensure diverse perspectives and design statewide initiatives that improve population health. In addition, there's a requirement to develop a statewide health equity plan. And so states are required to develop this health equity plan that's cross-sector, community-driven strategies aimed at reducing disparities and improving population health. And participating hospitals, those that are participating in the global budget, are required to create hospital health equity plans that align with statewide priorities and activities. And so the reason I just said put independent be partially because I think we see this as a opportunity, but to pivot for the state and use this as a tool to move conversations forward further in this area, which we know is really important to all of you. I think we agree that there's a very big need in this space in terms of developing those community supports, acknowledging that DSS can't do this alone. So I think we can jump to the next slide and get to comments from Alice and then Angela in terms of, you feel free to respond directly to Mark, and kind of the question is a little bit more on trying to focus it around program features that would be most important to integrate broader efforts on community investments and HRSN needs. So, but Alice, let me turn it to you.
Yeah, thank you. And I was so involved in what you were just presenting, I kind of forgot a little bit of what Mark said, but I think that, maybe CJ and I are in the same place a little bit around the plans. Whenever I see another plan being made, we're on year 3 or 4 of the Inc. Model, and have done a tremendous amount of work with Carelon, CHN, DSS on a population health model, very, very idiosyncratic to Connecticut, nothing like it across the country, where we're actually going into folks' homes and engaging in needs conversations around our children. And of course, children take up 40-50% of Medicaid dollars. I just think that what needs to be done is very extraordinarily costly. And the appetite to do that, in particular around equity, is low. I mean, we have an appetite for it, but we don't really have the buy-in of the state around the dollars that it's going to take. And, you can say, well, you got to give me proof of working. I mean, NFP is probably the most evidence-based practice in the country, as with chronic disease management. is really around connection and going into the home, understanding what's going on, what are all of the factors that are involved, from, shootings outside to, school discrimination. It takes engagement, time, and money to be in the community. And I just feel like we've done a lot of this. We have some, operational models now with Inc. We have Unite Us connected to the Zane database. We're doing the needs conversations with families. It's like, let's just take what we've done. And someone else said this today too, is we've done it. Let's do it. And I know that you can't just go out and say to OPM, we need $80 million. But, the comment I want to make to Mark is I hope everybody has seen phase 1 of the Medicaid study. And I know the commissioner wrote a beautiful report on that. But we have an enormous waiting list, right? And the reason is that we are paid 130% below what a 5-state comparison is. And I've had to increase staff clinical salaries 20 grand at least to keep them in after COVID. So, unless there is an appetite for the state to really, truly do this, and I agree with what you said earlier, it's not just DSS whose responsibility it is. There needs to be braided and blended funding. But until I am convinced that the state is invested in spending these dollars that are needed, we can make as many plans as we want. It's costly, and it's a lot of people's energy. So I don't mean to be a downer or whatever, but I've been in too many statewide meetings this week. So thank you.
Thank you, Alice. Angela?
Yes, so just to follow up on a statement I made earlier about language and competency, that whole intake scenario, when it comes to, for the benefit of any of the listening audience, HRSN, health-related social needs, if you're not communicating appropriately for an intake form, odds are you're not going to be communicating effectively when you're talking about primary care and addressing someone's social needs. So that's number one. So again, competency training, workforce development, that you've got to lean into that. The other thing, plans. I agree with Alice. I cringe when we talk about another plan. Plans versus implementation. It's great to have these plans on the shelf. How do they work on the ground? How are we connecting the dots, resourcing the plans in action, and so that we can have our healthcare system move from sick care to well care and giving folks incentives for sustainable wellness. That's the conversation and the details I'd love to see.
Thanks, Angela. Polly?
I just wanted to, respond a little bit to what Mark was sharing. Since we met last, I don't know if folks saw the article about Connecticut 211 having staffing challenges, having a lot more referrals to them. And I think that speaks to this overwhelming need that is out in the community, and a lack of support and infrastructure. And I think if that's a support and an infrastructure that can be shored up through this process, or how thinking about what those existing infrastructures are. But I think it really speaks to the challenge that we're talking about. If we're expecting screening on all of these patients, we know, particularly in this population, we will find individuals who will have needs and, will want to do something about that. For our referral, and we use Unite Us as well, Alice, most of our referrals, the bulk of our referrals go to the community action agencies. They've been, a tremendous support, and they are, located in many geographies across the state. And I'm curious if we've engaged with them at all, and specifically because I think they have a skill set here that can be very valuable. But if we were to ask them, what would it take to do this and to scale up your resources? Some of the feedback that we've had from our community health team that is engaged, with them is, bringing, organizations to the table sooner rather than later, particularly if you're talking about a head and a statewide model and a governance structure, to think about that. And then, I haven't studied ahead in great detail, but one of the provisions that I think is relevant to those of us with employed practices is that I believe the hospitals would have to participate in the global budgeting in order for our primary care practices to take advantage of the AHEAD model. And that might create a condition that, we haven't studied. So I just want to flag that as, a potential consideration for some of the hospital-based organizations that also provide primary care. And have you looked, Brad, at other, are we putting all of our eggs in the AHEAD basket, or are there other alternatives? Because again, we've all done a lot of work here and are very, I think, engaged and interested in primary care reform. And I don't know the feasibility or likelihood that the AHEAD model would move forward and how it kind of crosswalks with all the things we've already been discussing here.
Brad, I can respond to that really quickly if you'd like, but
yeah,
I say, no, that's a great point, Polly. I mean, we don't know if we're going to get ahead or not. We do have, just to forecast a bit, it's not a work group, it's a report that DSS will be working on this year that looks at how we can maximize benefits for our beneficiaries. It relates to legislation that passed in the previous legislative session. I remember the bill number, I remember the act number, HB 6669. So it covers some of the areas that we've been discussing, around equity, social determinants, but does offer us an opportunity to highlight, what we can do more globally as a system to address health and related social needs.
And I'll just add, Polly, to the conversations we've been having here, especially on primary care AHEAD, on the Medicaid portion of it, there's a lot of flexibility with what state Medicaid programs are able to do and align with primary care AHEAD. So it's actually built with a lot of flexibility in mind, so that there's the actual construction of it is really done in collaboration with states, and they will defer to, in our conversations to date, an understanding is they defer a lot to the states in terms of making those design decisions. And you have to have meet certain requirements, but Connecticut already before this, just with our existing programs, meets the requirements with our PCMH and PCMH Plus program. So that won't be a barrier to the work that we've been doing to date, so to speak. Robin?
Thank you so much. I think what I want to add, and just in terms of really looking at the AHEAD model, and also what we're all kind of talking about and sharing with, even as it relates to evidence-based and looking at race, ethnicity, and language, and then also looking at the intersect with the primary care and persons that are in the community, along with using possible CHWs. I think that I think there's a lot of work to do around that. And I do think that, one of the things I think that would really concern me also in all of this is that, really having a understanding and really doing a deep dive and really understanding what it means to address disparities and also what it means to address, health equity. Just like anything else, evidence-based or talking to people, interviewing people, it always could be the fact that some things are actually shared, and then some things that may be uncomfortable for people, may not be shared, also. And so, it may appear that there's a voice in it. It may appear that this is what the community is saying, but it's also, what also is not being said of those things that people are uncomfortable about, and knowing what that might mean for them to be able to embrace something like that and to really be able to share with that and to also be able to invest the money that's also, you can build any model or you can get evidence-based or anything else. But if you don't really put those dollars in there, and to sustain it, and that's one of the things I think that we lack a lot of times. We're willing to put dollars in the at the beginning of it, but really to look at those things that and pivot and do some other things that really means that to really be able to really address health equity, and as we really learn about and as things do come up, to really be committed to really sustaining these projects. That's where we kind of fall down a little bit. So, and that's what also, to me, gets the community riled up, in that we continue to perpetuate the system of really saying that we're doing health equity work, saying that we're addressing health disparities, but we continue to be at the same table, really talking about the same thing. So to me, I think we have a lot of work to do, around, what this model will be and what also the sustainability of this, and also what ways are we able to pivot as we continue to learn new things, and also as other things, may come up or come forth. And I think about, like, even as we talked about, housing, and also as it relates to, a workforce that's able to, be there to sustain, the project also. So I think that, those are some of the things that I just wanted to share as I'm listening to everyone, share some of those things that, you really have a little bit of a sample. So, don't think you have everything because you spoke to a couple of people. But this requires ongoing input, ongoing conversations, also talking with organizations that are already on the ground doing the work with CHWs. Thank you.
Thank you, Robin. Ben? Ooh, Ben, will we lose you? If you're talking, can't hear me, unmute.
I was on mute.
Okay.
So, I'm looking forward to learning more about the AHEAD model, and specifically how, since it sounds like we're at the place as a state where we're applying to participate, learning more about how DSS and other agencies are, thinking about the program and what you're excited about. I think there's still a lot of unknowns, and it's being pursued in the context of many other changes that we're making to the care delivery system and the payment system in the state, including the cost growth benchmark, the primary care redesign work that we've been doing. And I'm sure that we're not putting forward an application without engagement with some of the key stakeholders that would be impacted. And so I guess my question to you would be, based on the conversations that I'm sure you've had with stakeholders, what are some of the things that you're hearing about the AHEAD model? What are people liking about it? What are they concerned about? And why is DSS feeling so confident about the model that we're going forward with an application now?
And I think I just say, I think there's a still ongoing discussion of submission of the application. We're working very closely with our partners on that. I don't know if it's worth going down Ben, totally appreciate the questions. Not sure we should spend too much time, but definitely there has been some engagement with other stakeholders that would be part of this. And for those who haven't tracked, at least again, there's a couple major parts. The hospital global budgets probably is the most significant. The primary care ahead component affects fee-for-service Medicare and has a few pieces to it, but one of the major is there is a PMPM for care management that's associated with it, and it's a there's some other, obviously there's some other pieces, but I think generally the goal from the CMS side is to align with what the state Medicaid program is doing and provide some flexibility on that side. And so that's where this work that we're doing, the opportunity for some alignment and multi-payer alignment, I think, as we've discussed, like the need to make sure that that DSS and Medicaid payments aren't going off on their own ship without thinking about what others are doing for alignment. And this, I think, does lend itself potentially well to that. Mehul, do you want to add anything else?
Sure, happy to. I'll just answer very briefly. I think that's a great question in terms of stakeholdering and what feedback we got. I can summarize in saying I think the most sort of drastic or transformational piece of that is obviously the hospital global budget. And in the conversations around that, I think there's in general interest/curiosity to learn more and to understand whether that would make sense for the various stakeholders that would be involved from a fiscal standpoint. So that's kind of the summary of the conversations with hospitals and hospital systems.
Mark?
Thanks, Dr. Richards. So a couple of things about AHEAD. So we had, I've spent a lot of time looking at the AHEAD notice of funding opportunity and some of the technical detail on the hospital global budgets. And I think one of the things I think for everybody on this call to know is that this is the most radical proposed reform in hospital reimbursement since the early 80s and the introduction of DRGs. It is the state's moving forward with an application in March without having consulted in a meaningful way with the Connecticut Hospital Association. So they're applying to participate in a model without having engaged the Connecticut Hospital Association in an examination of what this means. There is there's another opportunity for them to apply in August, but they are applying in March, basically mid-March, without there having been a significant stakeholder opportunity. And that's a concern that I think is important for the record. Furthermore, around HRSN and their 127-page notice of funding opportunity in the AHEAD model, there is one reference to, there's one paragraph about health-related social needs, and it is not a paragraph that suggests that there is necessarily coverage for health-related social needs, but they certainly suggest screening and referral. It's not that that's not an option, as Dr. Richards noted. It's up to the state to determine what it will do for Medicaid, and there's no reference of it being coverable for Medicare. And we all know there are a great number of older adults who struggle with issues like loneliness, food security, et cetera, for which that's an issue. In addition, the DSS early on had distinguished between health-related social needs, or HRSN, when you screen a patient and identify a food access, food security issue, problem with utilities, from SDOH. And CMMI and CMS also distinguish between those two concepts, social determinants of health and health-related social needs. A lot of the comments that I've heard, say, from Angela Harris and from Reverend Anderson and from Stephanie Clark have been around mobilizing community assets in the service of addressing root cause conditions that are driving the inequities, not simply screening and connecting folks to services, which is basically a fee-for-service solution. I mean, everybody's unhappy about fee-for-service, but HRSN coverage is essentially a fee-for-service solution to what is in effect a public health problem. So in the NOFO, the notice funding opportunity, there's not a single reference to social determinants of health or the fact that there needs to be a root cause upstream solution. There is no collaboration with the CDC. So unlike the SIM model, which had a collaboration with the CDC and required a state health improvement plan and that sort of thing, it really overlooks the extraordinary contribution that, frankly, inequitable and abhorrent community conditions are making to the health disparities that we see today and to the prevalence of health problems that we see today. So those are some of the other is that there's those are some of the main concerns we have when we look at the proposal on its face. It is an effort to reduce spending in Medicaid and Medicare over time, 10 years. As Alice Forrester's comments make clear, we're not spending enough on Medicaid. We don't have a problem with spending too much on Medicaid. We do have a problem with spending on some of the wrong things, but not with spending too much on Medicaid. In fact, if you compare us to our Northeastern peers, New York, New Jersey, and all of New England, we spend, if we spent as much as they do on Medicaid as a percent of total state expenditures, Guy Woolston has presented on this in the MAPOC meetings, we would be spending $2.5 billion more on Medicaid than we do today. So there is, in my view, this fundamental issue as to how much the state is investing in Medicaid and the well-being of the Medicaid population and the communities in which Medicaid beneficiaries live and work. And that there isn't really anything in the notice of funding opportunity that suggests a strategy for financing and mobilizing the powerful collaboratives that exist in communities today. Reference to health enhancement communities was made earlier. It's not there. So I'm encouraged, Dr. Richards, Dr. Dalal, by the fact that there's some flexibility around the design, but I think it's important that AHEAD not be represented as responsive to the things that have been raised in this committee, because it is not on its face responsive to the issues that have been brought up in this committee. Thank you.
Thanks, Mark. Yeah, and I don't think us bringing it up is meant to be completely responsive. I think there's all the needs will definitely the needs that have been brought up, and I think we acknowledge are not seen as like this is the only answer. You know, the AHEAD model itself, it does. It would be shocking. Even with the flexibilities, to be able to be that full answer, and there needs to be larger conversations about how to address those larger needs. So I think the point is taken. I think we're just trying to say that, and at least in terms of some of the DSS focus or on the primary and some of the primary care work, there is some other alignment opportunities through this. Again, not being the whole solution. Even AHEAD would definitely not be the whole solution. It would hopefully be a step in the right direction. Tiffany?
So I appreciate all the concerns that have been raised around the AHEAD model, and I do believe that there probably may need to be some more diligence in working with partners. I often am also left with the challenge of us just restating what is the obvious. We know that there needs to be further investment in Medicaid. We know that. We know that the state needs to come on par, not even exceed, but come on par with where other states are in their investment in Medicaid. And so that is, I don't know a person who would disagree with that whatsoever. And we've got to figure out a mechanism to go there. At the same time, our system as it currently is working with the limited dollars that we have is broken. There has to be a way that we are pushing our state forward with reform. I'm not disagreeing that there are some serious challenges with the way that the model is designed, but I'm also not for us staying with the status quo and repeating ourselves. We've got to figure out a path forward. And so I encourage us to think about the reforms that need to happen in general, and for us to think about a path forward and I agree we've got to figure out a way to continue to invest more into Medicaid. We are not going to be able to move forward without that. And we know that. And we also have to reform our system so that it works for people who look like me, because right now it's not working.
Thanks.
It's Guy. Thank you for that comment. And for everyone, I just want to say I'm sorry for joining late. I was testifying, but I'm here and going to carefully review the notes that Brad and others have shared. And thanks for your comment, Tiffany.
Alice?
Thank you, Tiffany, and I appreciate it. And I think looking at root cause reform is really going to be the issue. We had if you haven't had the opportunity to see the Office of Healthcare Strategies report, if I'm the right office, Dr. Gifford's report on the parity of behavioral health and insurance, commercial insurances. It's not, they're using the ABCD, comparison, and it's not like, the full amount of people paying commercial rates for insurance. But it's interesting to me that when Medicaid remains where it is, the commercial insurers can stay where they are, and that, that then kicks off, and I'm talking more from a behavioral health point of view, it kicks off a whole private practice industry of cash only, right? And so there's just this, again, a missing group of people who can't afford to pay the insurance, and it's just it's just interesting how it's all linked together, and linked, of course, then to care. So I just want to add that.
Thank you, Alice. Ben?
Yeah, I just want to piggyback off of what Tiffany was saying. I think, it sounds to me like what you're hearing from all of us is that the Medicaid system as it is today isn't meeting the needs that we've been talking about for meeting after meeting. And certainly incremental investment is necessary, substantial incremental investment, and no one can deny that reform is needed. And I think as an organization that is deeply committed to serving the entirety of our population, regardless of who their payer is, I think it's really important that we understand the motivations behind the reform that we're looking to pursue, and have confidence that the models that we're going to pursue are meeting the objectives of that reform. And what I'm hoping is that in the months ahead, ideally it would happen before the application went in, but in the months ahead, we learn more about the intentions behind the AHEAD model, why we're pursuing it as a state, and how it's going to meet and close some of the gaps that we've been talking about as a working group.
Thanks, Ben. And I'll just make sure to flag that in terms of it, at least some of the work that, and make sure I hopefully was clear that I think the work that we've been talking about from this group in terms of primary care redesign and AHEAD can be aligned themselves, but are not necessarily dependent upon each other. And the primary care redesign work and kind of the discussion we've had in terms of how we've set our care delivery priorities, how we set measures, and how we talk about payment, those can occur with or without AHEAD moving forward. And so I just want to make sure that's clear that that's not dependent, but more that the conversation around the need for HRSN supports, there's some opportunity with what some of the structure that AHEAD creates, acknowledging it's also limited and there's some flexibility. So there's going to be some need to figure out what that looks like if we're submitting an application and if we won. So I think, Mark, you highlighted that there is some nebulous components to it right now in terms of the language and what it looks like, and that there would be a lot of opportunity for further discussion for what for example, the statewide health equity plan would look like, what would that look like for hospitals that participate. Hospital participation is mandatory. That those hospitals that do participate do have to have a hospital equity plan. So just to say that there is some opportunity that could be aligned with this in terms of primary care payment reform, but not necessarily, again, dependent upon it, if that helps a little bit. Understanding there's still going to be an interest from, hospitals and organizations as to what does HED mean for everybody. And again, this is, I think, part of what we have to do to message that out. So just to say, Mark, I'm sure we can always, I don't think the state is always known to be the best in terms of messaging always when we want to be. I think we want to be, but there's sometimes challenges there. And so I'm sure we always can do a better job of making sure we're engaging our stakeholders. But just to say, we have been thinking very thoughtfully and carefully about this and whether it's aligned with kind of where the state's hoping to go in the long term. And again, we're still finalizing that application and internal review on that. Mehul and Guy, I don't know if there's anything else you want to add to that.
No, I think you represented the status correctly.
And I think just back, maybe just seeing no other hands at the moment, that to what Ben, I'm sorry, Mark, you had said about like whether we should be doing screening referral. I'll just put my hat on as a general internist primary care provider, and there's been a lot of challenges in terms of screening referral for years. Even I've been doing it for a long time, but I think the screening process as a provider is actually really important to provide the best care to the people that you're taking care of in front of you. And the reason I say that is, if someone has limited access to certain foods, they are on insulin, they're on certain medications, you need to know that as a provider to appropriately adjust for their needs. Same with housing, right? If someone doesn't have access to a refrigerator, they're on medications that need to be refrigerated, or they, and you have to work with people to prioritize. Maybe they have a list of 10 biomedical issues, hypertension, hyperlipidemia, obesity, et cetera, but they're going through a really challenging time for whatever reason, or they're having housing insecurity plus food insecurity. Well, you might want to bump those things up in terms of prioritization and minimize other things. And so I argue that for all healthcare providers, that we should be thinking about this as we construct really patient-centered care plans or person-centered care plans, that becomes a priority for providing the best care and understanding where people are coming from, regardless of if we can actually get them access to food. I hope we can. And that's been a struggle for a long time, or for housing. But just even doing that on a provider basis, I think is a really important thing that everyone should be doing. Again, this is putting on my provider hat here, because it impacts the best care that you can provide for people. And it is a really important part of, I think, how we should be moving forward as a care delivery system, even if we don't have those community supports available. So again, that's not necessarily the DSS perspective. That's the Brad Richards Chief Medical Officer perspective here. But Polly, I see your hand went up, so you want to turn?
Yeah, no, I appreciate that. And we've talked a lot about that internally as well. How do you change the care plan? How do you modify the approach for your patient care, knowing that these are barriers that exist? But I do think, and it's not just in this conversation, but nationally, health-related screening is being linked with referring. So it is creating this conversation where it's one and the other. And I think, based on the framing you just shared with us, kind of broadening the lens of what do we do with the information that we're capturing, and how do we use it to personalize the care plan for that patient.
Thanks, Polly. And I also just want to acknowledge that challenge. I personally, as a provider, have been challenged with not being able to find someone housing or food, or making their food access, and knowing that, gosh, referring is really hard often when there's limited resources, and that can be really painful when you're like, there's not enough resources to refer people to. So I just want to also acknowledge that challenge, but the opportunity for screening, I do think there's a pretty significant impact that can be had on that care plan, even outside of getting those resources to people. Any other commentary here? We're getting close to time, and I just want to make sure, actually, if seeing no other, I think we'll move on to just kind of moving on, doing our next steps wrap up. Just want to thank everyone for the very thoughtful and engaging commentary. So not surprising given how engaging it's been this past entire year. So we just want to say we really do appreciate it, the thoughtfulness, the care, and the compassion that's gone into this all along the way. So as we're wrapping up phase 2, we're looking to think about phase 3. So really in phase 2, what we've done to date is we've asked big questions and we've heard from all of you. And Angela, I'll get to you in just a second after this slide. And we've gotten a lot of your feedback on the various care, the program structures, including on the care delivery, performance, payment, and the equity strategy. We're hoping in the next meeting to kind of bring that all together and bring you something to react to, as well as kind of a next step forward for what we think phase 3 can look like. So that's the in-person meeting that we've scheduled. And that's going to be on, I think on the next slide, we have that as April 4th, if I'm not mistaken. Olivia, is that right? Excellent. But Angela, let me turn it over to you. We have about 4 minutes left.
Okay, just wanted to follow up on one of your comments. And as it relates to primary care and Medicaid, there are known locales in the state of Connecticut where there are high concentrations of people who use Medicaid as their primary form of insurance. With that being said, to me, it would make sense if beyond just the doctor's office, individual by individual, that the state would begin to look at dealing with population health strategies that saturate those areas where they have the maximum number of patients in the same locale. For instance, investing in addressing those barriers like food insecurity and rerouting some of those dollars to address bringing the resources, basic needs to that locale, whether it be urban or rural, where there are high concentrations of patients that use Medicaid. We have to think creatively. If we keep doing the same thing, we're going to get the same results. We have to start thinking outside of the box. And how can we maximize the use of limited resources?
Thank you, Angela. Appreciate that commentary. I think as we're about 2 minutes out, I think I'll just want to say thank you all for I think where we've come. I just want to acknowledge again, I think considering where we started last year, really have come to a place where we've gotten a lot of really important feedback and just highlighting, I think, Angela, your point about the needs of the community and the people that are served both by Medicaid and others, and that those needs are still, there's a lot of needs that are unmet and those challenges that exist before us. And again, that this process can't address all those needs, but there's a need to be creative, Angela, as you just said, to think about how they can be addressed. So I just want to say there, in our current reality of where we're sitting, there will be, I think, limited options. When we talk on April 4th, it really will be focused on primary care payment reform. But these comments, we will bring them back, and we've definitely heard them. I think there's a lot of internal interest and continues to work on that. And we do see, and I know, Mark, I said ahead, and as you said, there's a lot of nebulousness around some of the language. It does create opportunity in that space if that's a place that we're headed towards, or that we apply for and we ultimately want. Mehul or Guy, anything you want to say as we wrap up?
You teed up well, Brad.
Yeah, nothing else on my end. Nothing else on my end. Thanks, Brad.
All right. Thank you all. We'll look forward to seeing you on the